This is QD Clinic. Still's disease or not, QD Clinic this month is about febrile disorders, lessons from the clinic. Our case today is a 45-year-old female who presents to see me. Her problems began when she was age 40, and she presented with hives, tendinitis, arthralgias, and wrist pains. She went to her doctor. Labs showed that she had high liver enzymes, and these kind of went up quite a bit, almost like AST, ALT of greater than 1,200 and 1,800. She was admitted to the hospital and followed and biopsied. At that time, her ferritin level was 1,900. Her bilirubin was normal. Her aldolase was greater than 32. Her angiotensin converting enzyme was normal. She had a borderline anti-mitochondrial antibody of 1 to 40. Her LDH was greater than 900. She had negative tests for ANA, rheumatoid factor, CCP, ANCA, LKM1, HIV, and CMV titers, and her double-stranded DNA was negative as well. A liver biopsy showed acute hepatitis without cirrhosis. There was no evidence of PBC or granulomatous disease, and she was managed with steroids. Her other labs were really not that abnormal. Her SETI was only 4. Her CRP was mildly elevated at 1.6 milligrams per deciliter, and her highest white count was 13,000. She was seen by 2 rheumatologists and treated with high-dose steroids to get out of the hospital. And then as an outpatient, she had polyarthralgias, some swelling per her report, but regular and intermittent urticaria with fevers that would last for 3 to 5 days, and then rashes and arthralgias that she felt were unbearable. The fevers were usually 101 to 102 late afternoon or evening, last a few hours, would have some shivers, but no sweats, no defervescence and sweating. She had chronic fatigue, and she said the rash always preceded the fever. These urticarial itchy rashes were sent to the dermatologist, and they called it hives, and one did a biopsy, and it showed evidence of leukocytoclastic vasculitis and nothing else. So her predominant complaints are she feels intermittently crappy. She's chronically fatigued. She goes up and down on her weight. She has myalgia. She has intermittent fevers, along with intermittent diarrhea, dyspnea, numbness, depression, anxiety, and these non-pruritic hives. And now she has a metallic taste in her mouth. She denied any significant weight loss, conjunctivitis, uveitis, back problem, psoriasis, and was not having rash when I saw her. When I saw her, she was on 15 milligrams of methotrexate a week for 3 months, adalimumab every other week, and prednisone 15 a day, and hydrocodone every other day, PRN for pain, and was not doing well with chronic fatigue and pain. She said her last fever was, I think at that point, 7 or 8 years ago. Or, no, I'm sorry. When she first presented, her last fever was initial admission. And by the time I saw her, she was not febrile. On my exam, she did not have any swollen joints, enthesitis, nodules, contractures, or deformities. She had no tender joints and no swollen joints. But yet her CDI score was 16, really because of hack and pain and whatnot. Labs that we did showed the white count to be 18.3. She's on prednisone, remember. Her H&H is 14 over 42. Her platelets are 275K. She has a normal differential. Her chem profile is normal, with normal creatinine, normal LFTs. Yet her aldolase is elevated at 12.4, and her CPK is only 35. Her SED rate and CRP are normal. No evidence of immune complexes by C1q binding. ANA is negative. Her CRP also, as I said, was normal. Her quantiferon was negative, as was her alpha-1 antitrypsin level. IG immunoglobulin levels were all normal. And so she's not having an effect with methotrexate, prednisone, and adalimumab. She previously did not tolerate or do well with etanercept. And the question is, does she have Still's disease or not? And I believe she does not have Still's disease. She does not, in fact, meet criteria, either Cush or Yamaguchi criteria for Still's disease. But yet, I believe this could be an autoinflammatory syndrome because she has periodic, repeatable fevers monthly for 3 to 5 days. It's associated with rashes. urticarial and non-urticarial rashes. She has LFT elevations. And I think for these reasons, and what else? And then the arthralgias, which are sort of non-specific and related to her poor sleep. So she does not meet criteria. It was 2013 or 15, I think this was. We put her on Actemra. She didn't respond at all to Actemra. We tried to put her on canakinumab. Ilaris, couldn't get it approved. We sent for genetic testing for TRAPS. She's from Amsterdam. Or Copenhagen. She has these fevers that last for more than 3 days, but less than a week, and they're intermittent. So TRAPS might be a problem. An autoinflammatory condition that may have a genetic cause would have been great, but we sent for TRAPS testing. It was 2013. Never got it approved. Never got done. When she was doing lousy on Actemra, we put her back on the Kineret, and she did well. She got control of her symptoms from the fever and the rash within 2 days. And she stayed basically on Kineret for a long time. And when she transferred her care back home to Amsterdam, she was on Kineret and 2 milligrams of prednisone. So the problem was, A, not Still's disease, B, probably another autoinflammatory disease. Thankfully, it was IL-1 inhibitor responsive, and an IL-1 inhibitor responsivity, in my opinion, is sort of suggested by that high aldolase level. Aldolase is a very good biomarker for autoinflammatory and Still's disease, and usually when it's very high, they respond well to IL-1 inhibition, in my experience. Again, we considered a lot of other conditions, TRAPS, Schnitzler's, alpha antitrypsin deficiency and whatnot, but I think autoinflammatory was her best diagnosis. Now, I would definitely have gotten genetic testing on her for cheap with a battery of genes to better characterize that and better know what future therapy she would be on. That's it for Still's disease or not. Tune in for more QD Clinics.